The more the prognostic scoring systems are available in any disease, it's always advantageous. In the field of MDS, obviously there are a number of prognostic scoring systems like the IPSS and the IPSS-R. So definitely the IPSS-M, which uses the molecular stratification of these patients with MDS, has definitely added value, because nearly 94% of patients with MDS in this large cohort had genomic abnormalities, both cytogenetic and mutations, and these have helped to stratify these group of patients into different categories with different prognostic implications. The real world thing is obviously first one, applicability of it. One is to see whether centers are able to do these genetic markers so that they can use the scoring system. There are a number of countries who do not have availability of genetic mutations, so that is one deficiency. Number two is, even in centers who do have these gene mutations, they're not the complete panel as described in the IPSS, both the primary set of genes and secondary set of genes. And thirdly, even if we have all those genetic panels, sometimes it is very helpful to talk to a patient to indicate what the prognosis scoring is, but doesn't always mean that we will change the therapeutic spectrum, but it helps us to be aware of the patient's increased risk of progression and also prepare for further treatment. For example, you could have a patient whose IPSS are low risk, but they could have multiple gene mutations other than P53 or FLT3 or RAS mutations. Those could increase the scoring system to put them into a higher risk category. But if the patient is clinically well, transfusion independent, no infections, you'd still continue to monitor those patients. That doesn't come out very clearly in the IPSS-M, which is why I think it's back to clinical assessment and making sure those patients are evaluated, and also be prepared for future treatments like transplant if there is a change in the clinical status.